Welcome to ANA Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. Neurology and psychiatry, two fields, one organ system. Today, we'll focus on the intersection between the two. We'll discuss one common psychiatric disease, depression, and how new treatments for depression may inform how we treat other neurologic illnesses. ANA Investigates producer Dr. Rohit Das interviewed Dr. Helen Mayberg, behavioral neurologist at the Icahn School of Medicine at Mount Sinai, about her pioneering research in circuit-based treatment of depression, particularly deep brain stimulation, or DBS. Here's Rohit.
Dr. Mayberg, it's a pleasure to have you on ANA Investigates. Thank you so much for speaking with us today.
Well, it's wonderful to be here.
Dr. Mayberg, you are in a unique new role as founding director of the Mount Sinai Health System's Nash Family Center for Advanced Circuit Therapeutics. Can you tell us more about this responsibility?
Sinai gave me the opportunity to not just continue to complain about the lack of cohesion between neurology and psychiatry, but actually to test it out in a real world situation. What we are doing as what I consider the ultimate experiment is to basically say in the neuromodulation group to put together and live together the clinicians who are experts in DBS for movement disorder, for epilepsy, and for psychiatry, and to support them and integrate them with the scientists that do the imaging of circuits, the physiology of circuits in humans, and to bring in the psychologist as part of the team who can deal with not just behavioral health of getting a patient to surgery, but actually watch and help a patient deal with their brain in a new state. What I've learned is neurology and psychiatry are fundamentally different languages, and we need a Google translator. People use different words that mean the same thing, and then we don't even know it until we have the conversation together. And we're, as a team, learning that we're more alike than different. We are like the blind men and the elephant. We're all trying to understand a multidimensional system. And by doing it together, we can actually figure out where we're more alike than different and where actually we have independent and separate important things to contribute.
Dr. Mayberg, can you give us some background on the impact and burden of depression, including treatment-resistant depression in the American population?
Well, first of all, depression is not a disease, but a syndrome. It's a very common syndrome. It's estimated in studies to affect, 10% of the US population, probably the world population at any given time. And it's diagnosed solely by self-report. When we talk about the term treatment-resistant depression, what's really important to recognize is that's not defined by any constellation of symptoms. It's not defined by etiology, and it's not defined by a particular brain state. It merely means that you have a depression that doesn't respond to any treatment.
What's important for neurologists to know about treatment-resistant depression?
What's important to neurologists to know about treatment-resistant depression has to start with what neurologists probably need to know about depression broadly. And for neurologists, we really want to see disorders that we treat with having a biological basis or a target. And the question is what is that target and how might we conceptualize it? And so in thinking about treatment-resistant depression, I study it in the context of no neurological problem, but I treat and consider depression as a neurological disorder, meaning that it isn't just a chemical imbalance, but it's fundamentally the result of dysfunction of brain regions and their communication.
You worked on developing a network or circuit-based model of depression, which contrasts with the neurotransmitter-based model that many of us are more familiar with. Could you explain the difference between these different ways of thinking?
I think this really goes back to the history of our tools. When we didn't have ways to measure biochemistry, all we did was describe what we could see. And as neurologists, we waited till people died and looked in the brain to see if we could make any association between the behavior and the brain. And when that didn't work in psychiatry, it moved into opportunities to make serendipitous observations about when people were given chemicals that they had resulting mood symptoms, and made associations between changes in a chemical system and developing or alleviating certain kinds of mental symptoms, including depression. And models of chemical etiologies of depression emerged. It didn't really help much. It was really building etiologies of what was wrong with depression by presuming that the treatment itself, if it worked, must be the source of the problem. But, the brain, as neurologists know, the brain is not a bowl of soup, even though we add a chemical and essentially stir. And so they're really, really coarse approaches with chemistry because they have no anatomical specificity, except if there is anatomical specificity to the chemical system itself, like dopamine, where it is much more specific than, say, GABA or even a serotonergic agent. But with imaging, one could start to parse symptoms, locations, and brain activity in real time, and set up testable hypotheses to start to ask the question of, do chemicals actually map on to circuits? And can we actually go back and forth between these two conceptual constructs?
What is the advantage of conceptualizing depression as a network-based problem?
Well, in some ways, it allows us to search for what are the primary problems in the brain and what are those things that are adaptive, are compensatory. There's something very interesting about neurological training compared to psychiatric training. The focus on the individual at all times in psychiatry with the layers, and that all layers are not equally important, but are always considered at all times, as opposed to neurology, where you actually look to reduce down to common patterns. And I think that looking for common patterns that you can test whether they exist or don't exist has been the approach and the importance of taking a neurological strategy, a circuit-based approach to a very seemingly non-specific syndrome. Because in fact, if you take people who meet standard symptom-based criteria for a major depressive episode and you scan them, you can see common patterns. If you take patients with neurological disorders that have depressive syndromes, you can find common brain circuit patterns regardless of diagnosis. And I think that logic is really what we're talking about here. And that logic can be tested, and then, like any null hypothesis, it can be disproved or proven.
How well do we understand the networks that underlie depression? How large are these networks, and which parts of the brain are involved?
So what's interesting is, the very simplistic notions in the early days, going back to the 80s, was to basically say, we don't have access to complex dynamics of the brain, so let's kind of look for large functional changes in the brain and see what we get. And what's evolved over time, as the role of the frontal lobe has always been, no pun intended, front and center, the best replicated finding across all studies of all times is the involvement of the frontal lobe. And in the early days, it was that low activity of the frontal lobe was common across various groups of depressed people. And so there seemed to be this common theme that if you disconnect the frontal lobe, it certainly has a role in depression. But then what happened was, as you started to look at, well, do those frontal abnormalities change with treatment? Do different treatments affect this low frontality in different ways? It started to get more complicated, and other regions became more prominent. And as dominant symptoms started to emerge, one could see that the frontal lobe was involved, but it certainly was not the whole story. And more fundamentally, it probably wasn't the driver. Because people who are equally depressed can have either high or low frontal activity. And as the tools have evolved, the capacity to look at how regions talk to each other within the same scanning session or in real time or over time with treatment has really brought out that it's what is the combination of brain regions that impact the frontal lobe or get signals from the frontal lobe that we have to think about. So if one starts to think about depression as failure to self-correct, failure to compensate in the setting of a stressor, then we're looking at the dynamics of the brain, which really requires one to think about how does the brain compensate in redundant pathways. And this is really what neurologists think about all the time. How do we think about a patient with multiple sclerosis? Why do some multiple sclerosis patients present with a single episode? Others present with a relapsing and remitting picture. And what is that magic place where a patient who has generally recovered actually converts to a progressive course of their illness? Depression acts the same. So actually using the kind of models that are used in multiple sclerosis or in other disorders where there's ability to compensate up to a point and then you can't, is how we have to think about circuit dynamics in depression, as well as what is treatment-resistant depression.
How can we modulate these networks to enhance recovery?
So, one strategy to the work is to say, look, it's too complicated, but I've got a scanner and I have some very well-known treatments, and we can take those known treatments and we can deliver them and we can look to see how the brain changes. So that how your brain changes on therapy is fundamentally different from how your brain changes on medication. But it turns out that actually they affect a combination of brain regions. Some of those brain regions overlap, but the two treatments affected in different ways. And then you say, well, how can that be? Well, then one can look at what the starting place is in the brain and actually come to recognize that if one adopts this logic, that you're not seeing the primary problem, but you're looking at the primary problem plus what a patient does to compensate, you're treating the compensation. And by knowing the starting place, you can give an appropriate treatment that corrects their brain rather than the mean brain. And so modulating the brain, that strategy, and recognizing that a depressed person, their brain can be in different states, and understanding, just like, in a stroke patient, there are only so many compensatory strategies before the brain dies after you occlude a vessel. That what is the state that a patient's compensatory brain is in, and can we treat in essence by brain type? That's been an approach we've taken to understand how do we pick therapy or drug in people presenting for the first time with the depression. Maybe if you know what nodes in the brain are changing with treatment and what nodes in the brain don't respond to treatment, one comes to realize that maybe the brain can be in a state that you have to help it to move in the right direction by doing something to it directly. And that's where really neuromodulation as a construct has come into play. And without fundamentally buying in to the notion that a particular syndrome can be conceptualized and objectified as a circuit disorder, you have no business trying to modulate it with a treatment that has anatomical specificity, which is what something like transcranial magnetic stimulation is, and more fundamentally, what deep brain stimulation is.
What can we learn from these approaches that we can apply to other neurological disorders?
So I think when one thinks about all of this work over many years, the idea of doing deep brain stimulation for depression was totally dependent, not just on a model of depression and a node that seemed like a suitable and likely best candidate, but was totally dependent on all the work done in movement disorder that had defined basal ganglia circuits, defined their anatomy, their connections, their physiology, their aberrant state, and also realizing that you could make lesions very selectively and change the dynamics of an entire circuit. That logic laid the foundation for approaching neuromodulation for any other disorder, whether it's tremor or dystonia or epilepsy, or even now Alzheimer's in the neurological domain, is balanced by the same logic for certain psychiatric disorders, which in animal models have a very clear circuit topology. Addiction, obsessive compulsive behavior, and depression in animal models have been translated from these human imaging studies. And that lays the fundamental starting point for saying which node is accessible and is likely to affect a primary symptom. And that's how the field has evolved.
What are the most exciting things on the horizon in your field? What should ANA members be looking out for?
So one of the things I think the future holds, and the future is quite exciting in the neuromodulation space, is that across diagnoses, we now have access to tools and devices that let us implant in more than one place safely in the same patient and actually tune the different circuits for different purposes. And I'll use the idea that up to now, for me, we treat psychiatric patients and the psychiatric problem as its own problem. But in fact, depression or mood dysregulation is part and parcel of disorders like Parkinson's and like epilepsy, two disorders where neuromodulation is already being used, so that one may fundamentally be able to isolate and interrupt a seizure onset in real time with a responsive neurostimulator. But the presence of depression may also be targetable, and hitting both may actually have implications on how well a seizure patient's actual recovery with neuromodulation is. And if we actually embrace, acknowledge, and study how these non-motor fuzzy systems actually interact with our more discrete motor symptoms, we actually won't just be better understanding how the brain really works, but we'll actually be developing strategies that can treat the whole patient. And that's really what our patients want.
Thank you so much, Dr. Mayberg, for that very, very interesting and very erudite discussion about this issue. Thank you so much.
Okay, you take care.
That was ANA producer Dr. Rohit Das interviewing Dr. Helen Mayberg, behavioral neurologist at the Icahn School of Medicine at Mount Sinai. To hear more episodes of ANA Investigates or to submit your idea for a future podcast, you can visit myana.org and click on the Education tab. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Drs. Megan Ritchie and Romer Giaccaden. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.